what made you become a doctor, Dr. Deering?
Well, I guess the answer to that is my father. One of my first memories is I was going to be a doctor. I never decided that. We never talked about it. I just simply everything all the way through high school, college, to medical school. Simply, I was going to be a physician, and I didn't find out till after I graduated from medical school that I never wanted to go. But I was really very glad that Dad sent me. I wouldn't have had anyone's nearer life if I'd gone off on my own.
Where did you attend medical school?
What?
Where did you attend medical
At
school?
Harvard Medical School.
And what year did you graduate?
1943. The first, although there were two classes graduated that year because it was wartime. It was 1943A.
Do you remember what the tuition for your medical school was?
I never actually paid it. My dad did, but it was probably in the neighborhood of $500–600. College was $350, and it seemed to me medical school was a little less than twice. Although I don't know. He paid all my bills and never had any trouble. He never saved up for it or anything. They were just current expenses, and he could handle that very nicely.
Did the tuition ever get to be so much in those days that it influenced the choices of young doctors in terms of where or how they practiced after that?
Well, I know in college the tuition went up from 300 to 350, and a couple of fellows dropped out because they couldn't afford the extra 50. In medical school, almost everybody was better set financially than that. It was not a question. The question, as I understood it, when I was looking for what I was going to do after graduation, was to pick a hospital where my father had done that. He went to City Hospital. He got to be superintendent for a while. Went through all of the things there. City Hospital. As time went on, I became interested in psychiatry, and they became disinterested in psychiatry. And then St. Vincent Hospital came along and established a psychiatric unit, which was absolutely wonderful. And then I got on the staff there, and I've been on the staff till I retired.
How do you think the cost of med school today influence the choices of young doctors?
Oh my. Several people I know have to look for a high-paying specialty in order to pay for the $100,000, $200,000 loans that they're going to have to face when they're out of medical school, and that to me seems too bad. Certainly, my own experience. I started out as an intern at $13 a month in St. City Hospital. I went up to State Hospital for psychiatric training, and I think we got $5,000 or $6,000 a year there, room and board, family and everything. But the money was simply not important. There was enough money available to live married, not luxuriously, but quite comfortably. And it's entirely different now. Yeah, I know that. I first started to make house calls to my father. I had bought a very nice but very inexpensive little Chevrolet, and I went over to one of the ladies. She said, try to make an impression on her. And she came to the door when I drove up and said, Doctor, next time bring a big car. So that was about the only financial pressure that, and it wasn't too bad. I really liked the big car too.
So what made you choose your specialty of psychiatry?
Well, I left medical school thinking that was the last thing on earth anyone would ever want to do. The psychiatrist there had, the one thing I remember him teaching us was that you really ought to get into psychiatry. It was the only place where you could do human experimentation without permission. And I'm sure he said some more intelligent things than that, but I got into City Hospital working with Dr. Foster Vibber, who was a neuropsychiatrist, a very fantastic kind of person. And he did almost everything without laboratory work, without testing, without anything. He could come to amazing conclusions just in his own skill and ability.
Would you like to talk more about your residency or your internship or anything before you started practicing?
Well, the internship was mandatory at that time, and I am tremendously glad that I I took it because it was a rotating internship, and we had 1 or 2 months in each of the major specialties there, so that I did probably 75 tonsillectomies alone. I did 13 appendectomies alone, just having seen them. And I did a number of other things, assisting, so I understood quite a bit about surgery. We had a little taste of having our hands in every single one of the specialties, and it was wonderful because I had a much better idea afterwards of what other physicians are doing than what I had early on. What many of the people are getting now. When you go into residency, you pretty much, I feel you have to specialize quite early. You can't afford to go flying around all the medicine. There just isn't time in the world to learn what you have to learn. But it's too bad because the breadth of this, some of the residents said that we were probably the last of the men who would know a little bit about everything in the world. Not everything in the world, but at least everything in medicine. We had a finger in everything. And it was much easier dealing with other doctors later when I wasn't touching any of their things, but still knew basically what was going on.
And from your residence, you went on to City Hospital and started practicing, is that correct?
I went up to State Hospital with the intention of staying there several years. I'd been there a little over a year when my dad got sick and confined to bed the rest of his life. So I walked in, took over his practice, everything, office surgery, house calls. House calls are fascinating things. You learn a tremendous amount about going into somebody's house and seeing how they live. You find out things about them that will take you 6 months to learn in a psychiatrist's office. And the experience doing that was wonderful. There's been so many changes, though. It was very good for me all the way along.
Would you care to talk more about a typical day early on in your practice?
Oh my. Well, the first few, I had a fairly small number of patients, but the patients began to trust me. And I was soon working the 8 or 10 hours in the office with a hospital practice, and being quite convinced that everything in the world depended on me. I was working probably 100 some hours a week. When I got married and had a couple of kids, my wife got a little upset about that. She said I ought to spend more time learning my children's names. And I fortunately, I was very lucky with that part of it, that I've been in practice 7 or 8 years when I got pneumonia, and I chose not to take care of it, which sent me finally to an old friend of mine, a specialist in lung diseases in Boston. He told me he wasn't too sure I was going to survive, and if I did survive, I'd probably have chronic lung disease. Fortunately, all his predictions were wrong, but I had 3 months where I couldn't do a thing, and another month or 2 when I had to do very little in the office again. And I learned a great deal about not working 100-hour weeks, not putting in this endless time that, I thought all the doctors did that, and quite a few of them did, actually. I wasn't the only one, but I learned a great deal more about the people who were able to take time out. And I learned to take some time out.
When did you go to the hospital for your practice?
For what?
When did you go to the hospital on a typical day of practice?
When? Doing shock treatment, usually it was 7:30, 8 o'clock in the morning it started. And it would take me, depending on the number of patients I had there, probably up till 11, often 12 o'clock, and I'd go to have lunch and go to the office.
Okay.
Frequently at the beginning I didn't have lunch because I didn't have time. But I learned that that's not a great idea either.
Who were your patients generally? I mean, where did they live? And just really what kind of people?
Well, Dr. Vibber, who got me interested in psychiatry, was the only physician in the area that would treat alcoholics by name, by preference. And I learned a great deal about Alcoholics Anonymous, very interested in alcoholics. I had a considerable number of alcoholic patients in the beginning. I had, of course, in the beginning, my father's medical patients, about 2 years before I could taper them off and make sure they were cared for properly elsewhere. But in the beginning, there really wasn't very much money around, and I didn't need too much. Remember back then, my wife and I decided if I had $100, $150 a week income free to spend, that would be very good. And that doesn't take care of a night out too well anymore.
Did you use the telephone to talk with patients often?
Oh my, yes. I was 24 hours a day, 7 days a week, available on the phone if it was necessary. I know I would normally take calls till 9, 10 o'clock at night, as well as all day in the office. When I got sick, I found out that was rather ridiculous, and we stopped 5 or 6 in the afternoon. When I get home, I'd have perhaps an hour, just catch up on a few calls before supper, but try to get a little more time for myself.
So over years of practice, would you say that your typical day basically just decreased in hours, less basically?
Well, after I had the pneumonia,
Right.
We did take 10 weeks a year off in vacation time. And that was something quite practical at that time. As time went on, it was necessary to control this. Within the time I got to be 50, I didn't want to work 20-hour days. And as practice progressed, the last 5 years or so, I was 75 when I stopped. The last 5 years, I was doing mostly nursing home care, no office, closed the office, not seeing anybody on a private basis. And that was very good then, but I slowly decreased the intensity of my preoccupation with the medicine, began to be able to live a little bit.
So what made you decide to keep being a doctor once you had started practicing? What did you really love about your practice?
Well, it would have been hard right then if you'd asked me why. I think I've learned since that I very much enjoyed sharing with other people their physical problems, their emotional problems. And I had been, early in my life, pretty much of a loner. I began to have a great many friends in Alcoholics Anonymous. I was surprised there how important it was to me to be able to talk with these people. And they know how to talk. They stand up and say things that take hours and hours to find out in a psychiatric interview. They just say it to whoever happens to walk in the meeting, and you learn that they're very comfortable with themselves. And I learned, I think, to be a little more like that.
So what were the most typical illnesses that you dealt with early in your practice?
Oh my. Well, early in the practice, when in the hospital, of course, I had whatever specialty patients that you had in that assignment in the training. In my office practice, because I had my dad's medical surgical things to do, he did a great deal of physiotherapy too, and I did all of that for a year or two. As I began to be able to sort out where where I want to concentrate, what kind of people I like to be with. My contacts with Alcoholics Anonymous helped me a great deal. I was able to pick, I don't know, the patients picked me, I guess, but to picking people that would get along with me. In all the years that I practiced, I only remember once when I had to tell a patient I just simply couldn't make out where they were going, and I didn't think they were doing anything. Part of that was true. I was beginning to have a little hard of hearing, and I couldn't understand the lady. But for the most part, the patients were, I suppose, very much oriented the way I was. We used to know on a weekday we were making rounds at the hospital, or a weekend, covering for another physician, that without knowing who the patient's doctor was, if you talked to the patient a minute or two, pretty much you could pick out from the 8 or 10 physicians that were there what was going on. I stop and answer that thing. Same thing. The question of whether what the typical illnesses in the beginning of my career, we had very little precise treatment except the talking treatment in the very beginning, and we saw a great many neurotic people, or we didn't know any better than to call them neurotic. In the hospital, schizophrenia, manic depressive illness, number of other things, but those were probably the most common there. And while I was practicing, we had Thorazine come along, we had antidepressants come along, and that changed the whole pattern of what we were doing. Made a much broader base and a much greater ability to handle some of the very complicated, very difficult things.
How did the typical illnesses change over years of practice for you? For the first 20, 30 years perhaps, really wasn't just a very slow change. But as time went on, diagnosis became more precise, treatment became more precise, so that the pattern of what we did, we began to have medication, and that was just a totally new idea. I grew up with a lot of Dr. Freud as a background, and if I remember Dr. Freud correctly, he said everything in the world is due to childhood experiences. And it really doesn't matter whether you're an imbecile or a genius, that if you understand who you are and where you came from, what was going on, you could function very well in the world. I think we changed that quite a lot to the fact that now if someone has an addiction, someone is a schizophrenic, someone has any of the major psychiatric illnesses, there are ways of determining brain activity, response to medication, of things that separate these things out. We had just a kind of a hodgepodge collection of things. The insurance side of this was so nice when we started because the insurance companies required only one diagnosis, a nervous disorder. You could be a suicidal, depression, hallucinating, out of contact, schizophrenic, jittery little neurotic, and the diagnosis is all the same. You didn't have to reveal anything about the patient. Nowadays you have to reveal so very much that, and psychiatric information is terribly intimidating and terribly destructive to patients if it does get spread around. So what disease was the greatest challenge for you to treat early in your career?
Early in the career, when I got into psychiatry, the charge was basically $10 an hour in this area. I had a friend, a psychiatrist, who took 2 days a week in office in Boston, because in Boston you got $15 for the same thing. And he had a couple of patients that would refuse to go to the Worcester office anymore. They had to go to the Boston one because it was only a good psychiatrist who would charge $15. But the money rapidly went up. It was I think, $120, $130 an hour.
I asked what disease was the greatest challenge for you to treat.
Oh, I'm sorry. In the beginning, of course, the schizophrenics were probably the most difficult people to handle. Personality disorders, we were not as precise in labeling them then. Depression was a joy in many cases because we had a precise treatment with electric shock that was immensely effective. There was no, just a slow change to now. I think so much of psychiatry is passing out pills and knowing how to use those medications, use them adequately, and being able to make the diagnosis that allows you to pick a correct medication.
What was one of the most important breakthroughs in disease treatment during the course of your career?
Oh, I think certainly just the precision of using medication. That when I was working at the state hospital, probably the most effective sedation we had was cold pack or very heavy showers, various kinds of hydrotherapy. We had phenobarbital and bromide. They were, well, they helped the staff more than the patients probably then. And as the development of medication came along, the whole pattern of psychiatry changed. It was just amazing to see someone suicidally depressed, get them on an antidepressant, and 4 or 6 weeks later, they're back at work feeling just fine. And even with our shock treatment, that was not always possible. And every psychiatric problem has some effect on it with a medication, and it's certainly a very wonderful thing to have happen.
What was one of the most important breakthroughs in disease prevention?
It's a hard question to answer. There's two situations there. One was the more accurate diagnosis, ability to have a precise treatment for it, and beyond that, there was always the ability to use the old talking therapies. It's not really a breakthrough, of course. That's what we had to start with, but the change was dramatic. A very, very great difference in how these things were arranged, how you handled them.
What is something that doctors take for granted now in terms of technology that you didn't have at some point in your career?
Laboratory work, testing of all sorts. When I was a resident, if we wanted to know what someone's hemoglobin was, we tested it. If we had to do a urinalysis, we went up and did it. There was a laboratory technician who came in sometimes, but not too often. And our dependents, you really didn't trust the laboratory for very much. The results were reasonably accurate, but they were so broad. They don't pin down to one very tight thing as they do now. And now with the various laboratory testing kind of procedures, you can have a very precise idea of what's going on with the patient beyond what they can tell you. And that certainly is a very important thing.
What technology is still being used today that you used back in medical school or early in your career?
Well, one of my favorites that's drug companies, I'm afraid, are trying to eliminate is placebo use. My dad was wonderfully successful at that. He had 2 drawers full of medicines. One he thought worked, which I didn't, as a medical student, didn't think they probably did very much. And the other one was strictly placebos. Hand-painted polka dots on the pills and vial-tasting medicines. and things of that type. But the great deal of change going on all the way through now, and we don't have that definite question anymore.
Describe one important invention that you've seen, and when did that start being used?
I suppose the most dramatic one was shock treatment. When I started in psychiatry, we were using it at the state hospital. It was crude, it was ugly, difficult to give. We had all sorts of fractures and everything else. As that was developed, memory in those days too, had a series of shock treatments. It was serious memory deficit. And nowadays, if shock treatment is still necessary, the memory problem is very much less. And certainly if you get to medication, that's essentially not a problem. It's easily handled anyway.
Did you have access to the new technology in your field?
Yes, we're not using very much of it, really. I think in the last 20 years, I've been retired now about 10 or 11 years, and the last 10 years before that, I was not doing the kind of work which would require a great deal of laboratory technical backup. But it was there. We did use it. We did have some MRIs. We had various X-ray machines, things that we could do that were much better, but not a great deal that affected me, because I was slowing down by the time I needed to learn how to use all that material, and trying to do simpler things.
Is there anything that you would like to see invented in the medical field in your specialty, or?
In the medical field, yes. I'd like to see some way of delivering medical care other than the system that's in effect now. A good deal of my final reason for retirement was I disliked very much the need for the technical reports that would take perhaps 40 minutes to write when I would only spend a 10-minute interview with a patient. And that there have to be better ways of communicating than the ones we're using, and the managed care problems set up communication so it's extremely difficult.
What were some of the most important drugs that you used early in your practice?
Thorazine was the first one I remember for schizophrenia. It was just a God-given miracle. Things that were totally impossible in control of a patient became quite possible. There were serious side effects with the Thorazine and all of its related drugs, which are, the newer drugs are very much better. They've much fewer side effects, much more effective, I think, than what we had then. But those changes happen as we go along.
Did you always have access to the drugs that you wanted to use?
Pretty much, yes. There wasn't really much restriction on it. They were pretty freely available, as much as any of the medical drugs were available. We did have things like insulin shock that required a whole staff to give it, a whole crew of people to do. Those things too begin to fade away. Laboratory work necessary for use some of the medication, liver disease, heart disease, things that changes that the medication might make, were quite easy to get the necessary work and to follow up.
Briefly describe attitudes towards smoking and cancer throughout your career, including your own attitude.
Well, my dad always insisted that cigarettes were coffin nails, that if you smoked a whole lot, which he did at the time, when he taught me this, he smoked 2 or 3 packs a day, But he, one time he just decided not to smoke anymore and he quit. He decided anybody else could do that too, and they couldn't. A whole lot of, oh, give me the question again, please.
Describe attitudes towards smoking and cancer.
Cancer was, in the beginning of my career, mentioned, but not anywhere to the extent that it is nowadays. The effects of smoking were treated, well, about as freely as the effect of alcohol is now. We're only beginning to get to the place where we're saying alcohol is a very dangerous thing, particularly for younger people. And the cigarettes went through the same kind of thing. They were for a long time very, very popular. Everyone in the movies smoked all the time. I did a little theater work, and I had to smoke a couple of times and really choked to death, which I guess was fortunate because I never really did pick it up.
Early in your practice, how did you see patients without money receive health care?
Well, early in my practice, we just saw them. I had many patients in my office that couldn't pay me at all. I had some patients like my dad's. My dad used to get paid in food or Italian wine or something of the sort from all of his patients on Shrewsbury Street. The payment, maybe say we stop this for a bit. I'm getting a little bit tired.
So do you think that everyone who needed health care received it early in your career?
For my dad, I think he gave care to everybody that asked. In my own career, when I started to practice, we had one whole day a week at City Hospital outpatient clinic, free psychiatric care. And I would see probably 10–15% of the people in my office never could pay me. And I didn't expect it. It really didn't make any difference. The money coming in was very adequate. We were living quite well. No great problem. Nowadays, just seem to be so very many people who don't have insurance, don't have this, don't have that. And while it may be available free, I have the impression sometimes that you have to take an advanced degree in communication or something to understand how you go about getting some of the free care. That unless you can spend a couple $100 a piece to get advice about how to get the free care, you can't get it. I have a family member who has been without a job fairly often, and she finally found out how to look up the free care places, and she does when she is out of a job, or when she is out of money for some reason or other, she does quite well. But I know there are an awful lot of people, particularly as I get to meet new people here in this town, that simply don't understand that care is available. My wife, as a physician, I'm concerned about her. She thinks it's very difficult. If she has a pain that only lasts for 2 or 3 weeks, she doesn't think she needs to go to the doctor for it. And I think she ought to go pretty soon. But what we're getting that straightened out pretty well too. But there's a lot of underserved people, certainly in psychiatry, more and more. If it gets so that it costs $5,000–10,000 to have a laboratory-made diagnosis for you, people for whom that's a year's income simply can't afford it. And it seems to me very difficult to know how we're going to ever provide the indigent people with the kind of care that the wealthy can afford.
Over the years, how do you think Worcester is compared to other places in terms of providing care for the underserved?
It used to be, experience I had was very good in the beginning. The more medicine gets organized, the less effective it is. You know, my son's an emergency care physician in Pittsfield, which is away from the medical center, away from the pressures. And I think the kind of people he sees going through the emergency room, uh, he sees those with an emergency without the money without the insurance to pay for it. He sees them much more freely than we do here. At least the experience I have going to an emergency room myself once in a while. They come in, they treat me really quick. I get seen in a hurry, 2 or 3 hours. Somebody else is waiting at 12, 14 hours. And there's not much choice about that. They're so busy here. I know out in Pittsfield, apparently he says a great deal better than that. Almost everybody gets seen reasonable lengths of time.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, I think several of us had some experience in Canada where they were trying a little, and certainly heard a great deal about Europe, European medicine, English medicine in particular. Well, just an example, I had a lady that I'd had in psychotherapy for about a year. She was doing very, very well. Her husband got transferred to England, so she had to go over. And they interviewed her in the usual way for the socialized medicine at that time, told her she would get immediate health care, immediate psychiatric care. And about 6 or 8 weeks later, she got the immediate assessment. She would have 20 minutes twice a year with a psychiatrist because she was in such bad shape. Fortunately, they had a lot of money. She paid to go up into Scotland somewhere and see someone up there. It cost her about 4 or 5 times what it would have cost here to go and see a very expensive psychiatrist. She had to take an airplane trip up there and back, sometimes spend the night over there, besides seeing the doctor. And we were afraid of that sort of thing happening to us. And in some ways it has. You have to have clearance to go from one doctor to another. My wife has to go to see another specialist. We've been there a few times before. Has a skin problem. They refused to give her an appointment until they had talked to the Fallon Clinic doctor who sent us, and we're not on Fallon Clinic insurance, and it made very little difference. I can see how hard it is for her. We got it straightened in no time, of course, but someone who doesn't know the system, it is difficult, and you can afford it, you can have insurance for it, and not know how to get it.
Were physicians involved politically on the topic of socialized medicine, or yourself even?
Very little early on. Well, most of us worked in the office in the hospitals, and that was our primary work. Now there's so much outside training, writing, publishing, so many things you have to do just to be in with the group and communicating with the group. I'm not sure it's a good thing or bad, but certainly physicians are a great deal more involved now, and probably will have to be more involved if they're going to continue to function in the systems we have it now. Hopefully, perhaps we can change the system a little.
What were your feelings on Medicare and Medicaid when they came around in the 60s?
When they started, they were just absolutely wonderful. We had patients coming into the hospital who the hospital just carried, but the hospital had to cut corners for them. They doing it for nothing. When the Medicare and the Medicaid came, the care became much more freely available. As it is now, I think the complexity of the care says it really doesn't make an awful lot of difference whether the patient's insured privately or whether they have Medicare or Medicaid. Medicaid, of course, provides less than Medicare, and Mass Health, which I've had a few run-ins with, has provided very, very little, so that it's very, and of course, reasonably with the state being not too good a financial place, it makes sense that they can't afford to pay all of these expensive things. I know there's still, to me, that isn't the best way in the world to take care of it, but I don't know, I can't imagine any better one right now. At least without being tremendously politically involved, which I don't want to be.
How do you think the government's involvement in healthcare over the years has affected physicians specifically, including yourself? How did it affect you?
Well, when I was in college, I was taking a pre-med course. One of the fellows in college with me was taking pre-med, and I said, "Why?" He said, "So I can get rich." I said, "What do you want to practice at?" He said, "I don't know. I have to find out what pays the best." And two or three of us in pre-med course were laughing at him and said, "That's absolutely ridiculous." Nowadays, with the expense of the training, with all the other things that go with it, the time before you can settle down, be married, have a practice, do whatever, as that gets more and more difficult, it gets harder and harder to go ahead without being influenced by the finances, without having to pick a specialty, pick a place to practice where you can make a living. I had a cousin who was the only physician up in northern Maine for something like 100-mile radius, and he'd buy a new car every year because the car wore out. He'd get 50, 75,000 of very hard mileage on it in a year. All that's changed now. Nobody up there practicing medicine in that town. No one around at all to cover most of that area. I don't know what the people do. I want to go up sometime and find out, see what's happening. But it is more difficult.
How have you seen patients affected by the government and managed care over the years?
The patients that know how to manipulate the system are doing very well. The people who are unable or unwilling to learn how you get the managed care, having more trouble getting what I would have felt back certainly in the days when I was doing general medicine, I would have felt was adequate care.
Overall, how have you seen the public's access to care be affected by the government? Good or bad way?
I wondered about that myself. When I started to practice, well, I said in the hospital, if we wanted laboratory work, we did it. If we wanted x-rays, we took them. There were people around, but you couldn't always get their services. Nowadays, it is so complicated that it's very hard to get everything for everybody when they need it. I don't know just where we go from there, but I'm really glad to be out of medicine anyway, because it's a little more than I want to handle to try and provide all those things for people.
What would you like to see happen with the government in healthcare?
I wish I had an answer to that. It would be wonderful to come back to the place where the doctors and the patients determined what they needed together. Now it's determined by so many rules and regulations. The last few years that I practiced, my secretary would tell me that whatever we were treating a patient for was not permissible because they never got paid. So you had to change to the diagnosis. You had to manipulate things around, or just not tell the truth about it. To have a simpler system, just a very simple system. When I started practice, almost all payments were in cash, and $10 was a lot of money to give the doctor at one time. Frequently, yes, incomes, of course, a great deal less, but I don't know, people didn't seem to have too terribly much trouble with that. Or the doctor would do it for nothing. Nowadays, I don't know, it is immensely expensive to do so many of the necessary things. How that can be changed, how it can be made available is very hard to say. I know that there are certainly some things about managed care that have improved tremendously. 2 or 3 months ago, I had my gallbladder out. The workup was just unbelievably good. I tried to take every piece offered to me. I want to see what they were doing. The surgery, when I was actively doing surgery, get your gallbladder out. It was 6 weeks at least before you could do much of anything. I got through this very fine workup into the hospital very efficiently, very quickly. A day or two after I got in, or through the surgery, the doctor told me that if I was unlucky, it would be 6 weeks of recovery like it used to be. If I was lucky, I could get out in 24 hours. And he was wrong on both scares. I got left the hospital in 23 hours and 45 minutes. And the follow-up too was wonderful. I forgot one appointment. The doctor was after me to check on it, find out, make sure I didn't have any trouble. Very nice. That wasn't always true when we were doing surgery in a totally different atmosphere. But the good thing is the commonplace, everyday things are so well handled, and if you have a diagnosis that's off the book somewhere, it's extremely difficult to get it straight, not to spend an awful lot of money on it.
How have doctors' salaries changed over the course of your career?
Real salaries, in terms of quality of living, I don't know as they have too much. I bought a house for $15,000 when I started practice. It was assessed for about $225,000 the last time I heard about it. So that to buy a $15,000 house now, you've got to have a great deal more income. And the doctors that are making a lot of money, I think, are making considerably more than the average physician was. But all in all, the financial rewards are basically pretty good. And if you're not too particular about trying to get rich, you can certainly have a very wonderful time in medicine.
Where did most of your income come from in the early part of your career? Was it just from the office charges?
Primarily office, a little bit of insurance. The insurance, well, I said I think before that I gotten sick about 3 months out with pneumonia. When I've been practicing 8 or 10 years, the money. We actually made more money that year with only 9 months in the office because my secretary had time to collect from the insurance companies. But up until pretty much that time, majority of transactions medically were paid for by cash with the patients. And it was easy for them, easy for us. You put down it was either paid or it wasn't, and that was all the bookkeeping you needed. No reminders, no anything. It has changed. I know it was much nicer for both the patient and the doctor then, but it's certainly pretty impractical now. I just got a bill back from the hospital for one MRI for about $1,200, and I don't mind having cash in my pocketbook, but I really couldn't have paid that without the credit card. And those things are very necessary. It's a very necessary thing. You can't do without it, and yet I don't know how you can have very good care and have the finances like they used to be.
How has malpractice insurance changed over the years, as well as its impact on doctors' practices?
The level of malpractice insurance is ridiculous. Reading a little while ago, not in Massachusetts, I think, but another state, either obstetrician or a neurosurgeon, that their malpractice insurance was just short of $200,000 a year. And if you need 150, 200,000 a year to live reasonably, you've got to charge a patient 150 times what my dad did with his $3 charge for somewhat the same things, and there's a great deal of difficulty in what happens there.
How did you learn the business of medicine?
Well, I don't think I ever did. I was grossly untrained in anything financial. My dad always used to give me money when I was in school, and his practice provided me money once I started out, and there was enough there. I'm sorry, would you repeat that question?
How did you learn the business?
Oh, yeah. Well, I had a wonderful secretary, and she learned the business. She did know the business to start with. She'd done some accounting work before. She knew how to do it, and she taught me whatever I needed to know. Mostly she did it. I would just throw her the information and forget it until I saw the money come in. And fortunately, I didn't have to do more than that. But I'm glad I didn't, because it doesn't interest me. Well, I like to get the money, but the procedure for doing it, our friends have a wonderful time with just handling them the payments, the records, and the rest of it. And I get lost in them, and I dislike them, and it hasn't gotten any better as time goes on.
Okay, I'm going to move on to the next question. We're on to Worcester. Could you tell me some changes that you've seen in the demographics of the Worcester community?
Well, way back when we started, there were a pretty fair number of immigrants. Ones I had personal contact were largely Italian or Irish. Certainly now, the minority, whatever that means anymore, there ain't nothing but minorities, I think, anymore. But the spread is so much different. When I started practice, simple things like patients of color of any kind. I don't think Dad had one black patient that he'd known as a friend somewhere before. I don't remember any other patients of color. The Italian, Irish, some of the other groups, Swedish, quite a few of them. But now there just is everybody, and I go into the hospital and see 6 different languages posted up there to read. 2 or 3 of them I recognize, but the rest of them don't make any sense. And I realize that tremendous change there is in the background of the patients that are coming and the problems they're presenting.
Did the ethnic background of your patients change a great deal over the years?
Well, as you get more well-known and more specialized, I certainly tended to see more patients with financial resources, or adequate at least, and a few of them were very much more than adequate. So I'm not too happy about that. I had one man who, I believe he was, he had a world record, or a United States record, of leaving the country without having paid the least income tax for anybody that ever got away. But he left owing me $800, and he never paid me. But where insurance is available, the payment is slow and difficult, but possible. And certainly we were having no pain other than the necessary paperwork when I was stopped practice.
Actually, I asked, did the ethnic background of your patients change a great deal over the years? Yes,
because I began, when I first started, not just ethnic but just religious. We never saw any Catholics to start with. The Catholics told me, many of them, that who continue to come anyway, that they were told confession that they could murder their grandmother or choke their children or wife to death, but if they saw a psychiatrist, God would never forgive them. And then the bishop came along and built St. Vincent Hospital, and with the psychiatric unit, that changed entirely. Other things have happened along the way. The spread of information has just increased so much.
How have you seen women's health in Worcester change?
Women's health?
Yes.
Certainly in medical school, when volunteers are asked for medical evaluation of new treatment, new drugs, it was all men. And as a psychiatrist, I began to find a great many women coming in who had severe premenstrual difficulty, and the doctors say it's not important, just go home and forget it. And I found in Europe and a few places in the United States, there were some women doctors who have been interested in this. And I had quite a number of them for patients. I was doing general medical kind of thing at that point, but I did know what the treatments were, and not too many other people did. You had some more to that question, I think, too.
No, that's it.
Okay.
That was what were public perceptions of doctors like when you started practicing medicine?
Well, I know my father was next door to God, with many of his less well-educated patients, that he couldn't make a mistake. And that showed up to the fact he was never, well, he had one silly suit for malpractice, but that was the only thing in his career that ever came close to that. The attitude of, repeat that to me again.
What were public perceptions of doctors?
Yeah, the doctors, when I started, I had to be very careful if I said something as a remark that people took it as true. That was it. And I learned as a psychiatrist, you're not supposed to make that kind of remarks anyway. Doctors became less and less infallible, more and more subject to, not I think anymore subject to error, but subject to being called on for their error. So that nowadays the malpractices, insurance alone is just out of reach, in a specialty that has a lot of danger associated with it. And it does change the feeling of the patient toward the doctor. The doctor doesn't have the authority that he had before. And sometimes just having the authority to do something, to say, look at the patient and say, you're going to get better. And they did. I didn't know what was the matter with them. It didn't matter. They get better anyway. And if they believed you, that was fine. But that I can't imagine that would be result in a malpractice suit now.
How do you feel the role of the physician in the Worcester community has changed?
Well, we get to be more and more technicians. Certainly, so many of the specialties that depend on laboratory work, various assorted things, it's so very important that you have to be a technician. They have less and less time to listen to people. I find it's interesting to me going, some of the doctors my wife has been seeing, that they've never asked her how she felt about some particular thing. They never wanted to ask before. When I was in medical school, unless you asked 20 or 30 questions on that, that was malpractice. And nowadays, they ask what the symptom is and give them a pill. And it works pretty often, but it still changes the relationship between doctors and patients, which is, we're losing something.
Are there Worcester physicians that you admired when you started practicing?
Oh yes. Of course, the one that was most important to me was Dr. Vibber. Dr. Vibber, he could do just about anything. I interviewed a patient one day. We had a patient come in, rather sedated and not sedated, but very slow and hard to respond. I saw him. Dr. Vibber came in to make rounds. The patient's covered up to his neck with a sheet. Can't see his hands. Dr. Vibber asked him 3 or 4 questions. Listened to a couple of things that I had to say, and then there were several of us, the group, going around. He took us all aside for a couple of hours and told us the man's life history. How old he was, where he grew up, where his parents, and what the ethnic background was, how many children he had, where he'd gone to school. And I thought he's cheating or guessing somehow. And he said no, and he proceeded to tell us each of the things he had heard and seen. He made a couple of mistakes in the history, but it was amazing how much he got straight. And the attitude toward the physician, there were so many doctors who were intuitively right about whatever they were doing, whether it was surgery or medicine or whatever. Nowadays, I don't know, every doctor I go to looks at the lab work before he talks to me anyway. And I don't know, it saves time, but it also avoids sometimes chasing down something that's very important that the doctor would know that the patient doesn't.
What advice do you have for younger doctors?
Well, I don't know. My dad was a doctor, I'm a doctor. My son was a doctor. His older son was being aimed toward medicine, gently, but being aimed toward it. He had a pretty good look at what medicine was today, and he is now a fireman and expects to be a fire chief. He's had the training for it. And my second grandson, doing the same way, has done quite a lot of medicine, and that's it. You know, just he doesn't want it anymore.
Okay. Well, that brings us to the end of our interview. Thank you very much.
Okay.